Our next speaker is Dr. Samir Batham. He is from Radiation Oncology. He is consultant at HCG Cancer Center, Ahmedabad.
Very good afternoon, all of you. So I'll be speaking why I prefer definitive CTRT for T3 and 0. And I've intentionally put asterisks over here because, yeah, nothing in world, there are certain conditions which are always applied. I cannot pass a blanket statement that all T3 and 0s require CTRT, of course, when we have so many eminent surgeons, medical oncologists in your gathering. So this is the disease we are talking about, the supraglottic and the glottic T3s. And this is what you are seeing and we'll be seeing for next 10-15 minutes. Three of us trying to defend what we are doing and why we do it. The disease we are talking about, probably for T1, T2, again, although we can debate for the whole day, but we all agree that radiation and surgery both are the options. For the advanced diseases, T4 and plus, again, surgery, neoadjuvant chemo, CTRT, both, in fact, all these options, they have sufficient backing by the evidences. But when we talk about this particular subgroup, things are not easy. In fact, this was the reason why we discussed this particular subgroup. Things are not black and white. There are a lot of gray zones and which have to be kept in mind. So a quick background that these tumors, the stage 3, stage 4s, were historically treated by laryngeal total laryngectomy, and there was substantial functional morbidity and loss of natural voice. The treatment goals even then were clear. We wanted better cure rates, better survival. We wanted to have a better quality of life by preserving the larynx, and we wanted to minimize the treatment-related morbidity. A big question which was asked long back, can we preserve the larynx without compromising the survival? We know the classical Veteran Affairs trial. Good number of T3 patients were part of this study, and the results were favorable. And they suggested that yes, laryngeal preservation was possible, although there is no OS benefit. So over the next 30 years, all the patients were subjected to laryngeal preservation, and the survival kept on falling. There were many studies. They tried to find out what went wrong, and they concluded that this was the poor patient selection. All the patients of stage 3, 4 cannot be offered laryngeal preservation. There are multiple factors. They found out that stage 4, now we know that if it is a T4 disease, these are the patients who are not ideal candidates for laryngeal preservation. In fact, there were some of the studies which suggested that it was an inferior radiation technique which was not giving better control, although I do not agree fully with these studies. Why we worry about radiation? Of course, there are toxicities despite using advanced techniques like IMRT, xerostomia, PEC dependency, dysphagia. The list is long. But let me be honest, the list is long for all these things. Even for NACT or whatever surgery you choose, there are certain set of sequelae which we have to accept. In radiation, what we can do, that I'll be talking about in my subsequent slides. Coming on to what, Veteran Affairs more or less established induction. But the question was, can we omit induction and just start with CTRT, the RTOG 911, which again quoted by Dr. Krupa. Good number of patients of T3, 3-arm study, and they also concluded that CTRT is definitely better when we talk about laryngeal preservation and locoregional control. The concern of non-cancer related death, so we should never forget that these trials, they included a lot of stage 4 patients, bulky nodes, all these were a part of this study, and here we are talking about T3 and 0 only. So even the 10 years update, the findings were consistent. The laryngeal preservation as well as the locoregional controls were significantly better in the CTRT arm over induction arm. The McKenzie, and in fact, when you see the site-wise analysis, this clearly favors, particularly in oropharynx and larynx, concomitant scores much over neoadjuvant, and the differences are significant. There were multiple trials like Paradigm and Decide, which tried to solve the mystery of induction versus concomitant, all failed to show any benefit. And the GOTEC, of course, this was 2 versus 3. GOTEC clearly showed the superiority of TPF versus PF when we talk about laryngeal preservation and the larynx dysfunction-free survival. But let's come back to McKenzie's update, which came just 2 years back. Again, it also clearly showed the benefit of concomitant over-induction, and there was an absolute benefit when we talk about overall survival or when we talk about the EFS. In fact, this was a very interesting study, the bioselection, where they tried giving just one cycle of induction, and based on the response, they decided for the treatment. Somehow this strategy could not work. Coming on to CTRT versus surgery, there are certain points which we have to keep in mind, that there are no prospective randomized studies, and hence there's no strong evidences. And especially when we talk about T3 and 0 in particular. The only randomized trial was Veteran Affair, where the comparison was against TL. And nowadays we know that there are many conservative surgeries which are preferred. But most of the studies on partial laryngectomies, the TLMs, they are single arm studies. The comparison with CTRT is mostly in the retrospective series only, where the patient population, the surgical techniques, radiation doses and everything there is a huge heterogeneity. And we are not talking about type 1, type 2 chordectomies, especially in T3 and 0s. These are some major surgeries, of course, excluding TLM here. And all these surgeries, they have their set of indications, contraindications, their set of complications. So probably it is very difficult to compare surgery as a whole to CTRT. I'll be quoting 2 papers from the master himself, Professor Paretti, where he has clearly mentioned that for T1, T2 it is okay, but when we talk about T3, you have to accurately select the patients, the indications he mentioned in his talk. And particularly for T3, you have to be very selected. You cannot just consider all the patients for upfront surgery. In fact, TLM also have certain weak points. This is an Indian paper, an experience of near total laryngectomy, and I really like the conclusion what they made, that not only for patients per primum, but if you select your patient carefully, the outcomes can be good even in post-radiation failures. This was a meta-analysis which compared total laryngectomy, partial laryngectomies, TLMs, radiation, and CRT. Of course, most of them were retrospective studies only, and they also concluded that the OS rate were highest in CRT. Of course, this difference was not statistically significant. And when we talk about local control, yeah, the partial laryngectomies were giving it better. We have some data on surgical salvage after radiation failures, and in concomitant arm in the RTOG 911, 16% of patients fail, but they concluded that the laryngectomy following organ preservation is associated with acceptable morbidity. There are multiple other studies where surgical versus non-surgical treatment, particularly for T3, have been compared. The OS, seems to favor surgical arm, but there were a lot of limitations in these studies. Again, the patient population, the kind of radiation doses, there was a huge heterogeneity. There was another study which tried to overcome those limitations, and they concluded that CRT probably is not that bad option. There are other relevant issues as well. Most important is the evaluation of the disease. If you have not just 2 minutes, the last 2 minutes, the laryngeal function assessment is most important, and one of the most important guiding factor. The imaging modalities again plays a major role, because we have enough literature which says that you are likely to misdiagnose a T4 to T3, and subjecting these patients to organ preservation is going to be catastrophic. And radiation, as we have seen, has given in T3 patients also, we have seen decent local controls and survival. Of course, there are tools with the help of which we can reduce the toxicities, speech and swallowing rehab, which nowadays we are doing much rigorously. Previously it was not the case. We have better techniques. Protons, de-escalation and limited field radiation is an area of research. And the future probably will be guided by many other things, not just functionality, and they will be having all these markers. Then there are areas of research like immuno and biologicals. So to conclude, case selection is the key, and all patients, they must be discussed in head and neck MDT. It is important to understand and recognize the strengths and weaknesses of our own as well as other modalities. And this is what Kaustubh Sir has taught me in last 10 years. Evaluate your patient as an oncologist. you should not be biased as a radiation oncologist or a surgeon or as a surgeon or as a medical oncologist. You should always, look for the best, what is best in favor of your patient. So don't try to preserve a non or dysfunctional larynx. The LED-free survival, this must be an important endpoint whenever you are considering any modality. The bulky T3, this is how I take it, should go for neoadjuvant. If there's T3N0 with dysfunctional larynx, I would suggest surgery. For rest of all, I would say radiation or the chemoradiation is time tested and tested against time. So this is a famous saying by Bernard Baruch that if all you have is a hammer, everything looks like a nail. But when you work in a team, it makes a difference. This was not a nail, this was a screwdriver. You can use different tools to address different issues. Ultimately, we have to work in a team. We have to have each other's back so that we can do best for our patients. Thank you.